Hi, I'm Jen Mellor. Before I start my presentation, I thought I would just introduce myself. I'm a professor of economics and public policy here at William & Mary, and I've been at the college for over 20 years. I teach courses in health economics and health policy, and in my research, I look at issues affecting lower-income older and disabled adults who get access to health care through the Medicare and Medicaid programs. When I'm not directly doing work related to healthcare, I also teach a Call 150 seminar called The Economics of Bad Behavior. And perhaps some of you have students in that class this semester. In that class, we use economic tools and policy tools to study behaviors that have harmful effects on the individual or society. In all of my classes, I try very hard to make the material current and bring the real world into the classroom. It's important for students to see how what they're studying in class helps inform and understand the world around them. And that was especially important in the spring of 2020, when I was teaching my course, The Economics of U.S. Healthcare Policy, and the COVID pandemic was unfolding around us. There were many days that we spent in class talking about how COVID was shifting the healthcare system. So what I will share with you today is an example of some of the topics that we spoke about last spring, updated for today's audience. I'll share some lessons that we've learned from research and analysis about the effects of COVID-19 on the U.S. healthcare system. So I'm talking about the effects of COVID-19, and for many people, the first thing that comes to mind is this notion of dashboards. We're all very familiar with checking in with dashboards, sometimes on a daily basis, to understand the impacts that COVID-19 has had around the world, in the US, and here in Virginia, and here at William & Mary. Dashboards provide us with readily available data on tests and cases and deaths. In addition to all of this readily available data, though, there are metrics about the impacts of COVID-19 that are harder to see, and those are the impacts on our healthcare system. And as I start to tell you about those in this lecture, I really first need to explain what I mean by the U.S. healthcare system. To some people, the phrase healthcare system might sound strange, because in the U.S. we have a system that's anything but monolithic. It's perhaps fractured or broken, some might say. At best, a patchwork. So when I say healthcare system, I'm not talking about one particular program. I'm really talking about the decisions that are made by millions of different people, millions of different organizations on a day-to-day basis. And for me to describe that system to you, it helps to divide those people into groups. So one important group is obviously patients and consumers of healthcare. And another group is providers of healthcare. That might include physicians, non-physician clinicians, hospitals, and other institutions. And together, these two groups make up the heart of the system. And through an economist's lens, I see these groups as the buyers of healthcare and the sellers of healthcare. Into this arrangement, we can add other parties as well. We can add the private insurers and different levels of government. And these two groups serve as important intermediaries between our patients and providers. Private insurers collect premiums from individuals and their employers and distribute those premium funds to providers to reimburse providers for the care they deliver to patients. The government acts as another important intermediary, collecting tax revenue from taxpayers and using those funds to pay providers who deliver care to patients in Medicare and Medicaid. Obviously, this is a simplification of the U.S. healthcare system, but it's an attempt to show you the lens that I use when I look at the impacts of COVID-19. And in the talk today, I'll focus on the impacts that COVID-19 has had, starting with our buyers of healthcare, our consumers. And my thesis in this talk is this, that COVID-19 includes a series of demand-side shocks to the US healthcare system. And some of these shocks may lead to effects that worsen access to care, costs of care, and the quality of care in the US. And as I try to break down these effects to you, I'll be describing the effects at different levels. At the top level are the direct effects of COVID-19. And by this, I mean the effect of COVID itself, the threat of having COVID, the diagnosis of having COVID. And then below those direct effects are what I call intermediate effects. And here I'm thinking about the effects that are created by our responses to COVID, our efforts to mitigate coronavirus spread. And finally, at the base level are what I call systemic effects. And here I'm thinking about the effects on our healthcare that work by COVID's shock to the US economy. So I'll start with the direct effects of COVID. And here again, I'm thinking about patients, and I'm thinking especially about patients who are concerned about their immediate health. One of the first things that we saw in the pandemic was a surge in demand for tests. And tests for the coronavirus have significant benefits for patients, obviously. Beyond that, they also have significant benefits for society. One person getting a COVID test or a coronavirus test can have spillover benefits onto other people if that one person gets a diagnosis and then acts to quarantine themselves and mitigate the spread of the virus. So recognizing the significant benefits that testing has for both individuals and society, policymakers took pretty early action in the pandemic to reduce the costs of testing for individuals. And here I'm referring to some major pieces of legislation that passed in March: the Families First Coronavirus Response Act and the CARES Act. These pieces of legislation made it such that individuals who needed a COVID test or a coronavirus test were able to get it without having to pay a copay, that's if they had private insurance, and if it also provided funding to providers to deliver tests to the uninsured without a cost to them. Other changes in the Medicare and Medicaid programs made testing for coronavirus much more accessible. And as a result, most insured persons do not face a copay or an out-of-pocket cost for their coronavirus test if it's medically necessary. In addition to the surge in demand for tests, those early phases of the pandemic, and even continuing today, were described by or remarked by a surge in the demand for treatment of COVID. And unlike the policies on testing, there's been no comprehensive policy on how to pay for the costs of COVID treatment. In some ways, the way that patients are responsible for the cost of treatment mirrors the fractured system that we have in the US. Some patients are covered. Most privately insured patients are covered. Medicaid patients are covered because this program has historically had minimal or nominal copays. And many uninsured persons are covered in their COVID treatments as well. And these reflect major policy changes. The CARES Act included $175 billion for hospitals who found themselves treating uninsured patients with COVID-19. Policies in the Affordable Care Act require that certain types of insurance firms spend a specific share of their premium dollars on healthcare benefits for patients. And recognizing that patients would not be spending as much on other things, private insurers stepped in and waived copays and deductibles. for many of their patients. So yes, many patients have been covered for this expense, but some are not. Again, this is indicative of the fractured system that we have. Some Medicare beneficiaries who lack supplemental insurance coverage find themselves responsible for a $1,400 deductible for a hospital stay and 20% of all outpatient treatment costs for COVID-19. And privately insured patients who go to an out-of-network provider may be seeing surprise medical bills and may find that in the next few months, the cost-sharing waivers that their insurers have enacted will soon expire. So those represent some of the direct effects of COVID. Let me turn to the bottom of the pyramid, the systemic effects of COVID. And here again, I'm talking about how COVID has affected the demand for healthcare by working through its effects on the economy as a whole. And what are those effects on the economy? We've seen the US economy change rapidly in the past few months, from a time of historically low unemployment rates to a period of unemployment rates approaching 15%. The latest numbers tell us that the US economy is on the mend, with unemployment standing at 8.4%. But that amount is still relatively high compared to prior recessions. So what does this economic shock to the economy as a whole mean for our healthcare system? It means two things, potentially. High unemployment means that people are not seeing as much income from work. And in the US, where a lot of people get their health insurance through their workplace, job loss can mean the loss of insurance as well. And these two factors, an income shock and an insurance shock, translate into a shock to one's demand for healthcare. That's because income and insurance are two of the key drivers of healthcare demand. So we might expect that the income and insurance losses from the COVID economy will have a negative effect on the healthcare system by decreasing patients' demand. The question about the size of this effect is key. And one thing that we don't know yet is just how large those insurance losses are. We know that a lot of people have lost their jobs, but we haven't translated those numbers into losses in insurance coverage. And the reason is that we don't have great survey data just yet from the federal government. In the absence of that, researchers are using various micro-simulation models to use their best guesses at what job losses and insurance losses will be. And they're quite variable. Some estimates suggest that as many as 30 million people will lose their employment-based insurance. Other estimates suggest that only 5 million will. And the numbers of people who are estimated to become uninsured range from 3 to 8 million. So why are the numbers of people who lose their insurance smaller than the number of people who lose their employer-based insurance? Well, that has to do with movement from one category of insurance to another. A lot of people who are losing their workplace insurance through COVID may find themselves able to get coverage through the Medicaid program, especially when they live in a state that's expanded Medicaid to low-income adults. Virginia is one of those states, and in the Commonwealth, we've seen an increase of 55,000 persons just at one point this summer on our Medicaid rolls. Some of this may be from people losing their job-based insurance, but it's too soon to tell. So now I'll turn to that intermediate category of effects. And these, again, are the effects of COVID-19 that work through our responses to coronavirus and our efforts to mitigate coronavirus spread. So how did those efforts to mitigate coronavirus spread change our healthcare system? And my position is that there are shocking patients' demand for healthcare. So let me talk a little bit about the driver of that effect. When a patient goes to a hospital or a physician, there's a cost involved. We might think of it as a monetary cost. Others may say, well, we also need to count for the time cost of that care. In the pandemic, there's another cost that's created. Going to the hospital means exposing yourself potentially to the coronavirus and the risk of catching COVID-19. So this increased cost of going to the healthcare provider may have an effect of reducing demand, reducing utilization of certain types of healthcare. Now, it's going to be hard for us to disentangle how much of the healthcare reductions we see work through this intermediate effect. Because remember, those systemic effects of having less income and less insurance, those will also dampen healthcare demand. If one has less income, if one doesn't have coverage, one's less likely to go to the hospital or the physician. And of course, too, there are supply side effects beyond the things that I'm discussing here today. We know that closures prevented many providers from doing business, regardless of what patients would have wanted. So while these are hard to distinguish, I think there's some evidence that they're perhaps playing a role, these intermediate effects. And I'll show you some new evidence that's emerging. This slide shows the dramatic decrease that occurred in outpatient office visits during the pandemic. Outpatient office visits fell by nearly 60% of their pre-COVID levels in a very short period of time. And as months went on, outpatient visits increased in number, but they're still below, about 10% below their pre-COVID levels. And these are as of July, at the end of July, where the latest data was available. These are numbers that are based on large samples of patients, millions of patients, whose healthcare utilization is tracked through the Healthcare Cost Institute. So declines in outpatient office visits are one sign of these shocks to demand. Another sign is the specific decline that's taken place for an important type of preventive care, colonoscopy. Colonoscopy use has fallen by almost 90% as of the middle of the spring. And it has not nearly recovered to near its 2019 levels. So as of the end of June, it remained more than 30% below its 2019 levels. And this is in contrast to what we see for hospitalizations for childbirth, which have hovered pretty close to their 2019 levels. Important evidence that when it comes to elective procedures like colonoscopy, COVID-19 has had a significant demand-side shock. And we see this pattern too for mammograms, and as this slide shows, for vaccinations for children. And it's not limited to just ambulatory care. Hospitalizations have been on the decline for elective procedures like knee replacements, but also for care for heart disease and for diabetes. The ripple effects of these decreases in demand are important. First and foremost, we can think about the population health effects of what happens if patients are foregoing important, high-value, low-cost procedures like colonoscopies, mammograms, and vaccinations. Putting off one of these procedures today may mean that harmful health conditions develop years from now. And we won't know for some time whether that's borne out in the data. More immediately, though, we do see that there have been effects on our healthcare providers. These demand-side shocks to patients' utilization of care have worked their way into hospital revenue estimates. And in some ways, revenue estimates are too hard to quantify. We see decreases in patient demand that I've just described, but we've also seen increases in federal support for hospitals, including billions of dollars of funding for hospitals. So estimates vary widely on the exact size of the revenue shocks that hospitals are exposed to. And we also know that those revenue shocks are not the same for all hospitals. There's some evidence that's coming out that's informing us that those hospitals that are suffering the most from this shock in demand are rural hospitals and hospitals in urban areas that treat low-income patients. So if those hospitals close because of these revenue losses, we could have significant challenges to access to care for many communities. On the physician side, when it comes to physician practices, we may also worry about the same types of effects of patient reductions in demand working their way into supply-side settings. And surveys of physicians tell us that physicians are struggling too. They're cutting back on their hours, they're reducing the salaries of their workforce and implementing furloughs. And very concerning is survey evidence that suggests that a lot of physicians' offices are intending to close. A survey of physicians in Massachusetts suggests that 23% of primary care physicians and 42% of specialists are considering closures. Again, losing those physician offices could worsen access problems for some populations. So, if we go further out into the time horizon, we might even worry about more significant problems. As physician offices and hospital offices or hospital locations go away, we may be left with fewer sellers of healthcare. We may be left with more concentrated markets as one physician practice sells itself to a larger specialty practice, or one hospital sells itself or becomes part of a larger chain. And economic research here is clear. The less competition and the more market concentration there is, the higher the prices of healthcare. Consumers will pay more, insurers will pay more, and governments will pay more. So we need to be concerned about efforts to prevent this from happening. Higher prices in healthcare are sometimes said to be worth it if they result in higher quality. But the evidence from economic studies is also very clear here. When hospitals merge and consolidate, when physician practices do as well, we see the higher prices, but we don't see the quality improvements. A second long-term concern that we might have about having fewer providers is what this means to patient health. And in my own work, I've done some research that shows in areas of Virginia where there are fewer primary care physicians per capita, Medicare patients are more likely to be hospitalized for conditions that could have been prevented by good quality ambulatory care. So we should be concerned about the impacts of the COVID demand-side shocks on our future measures of hospitalizations, which are a good health metric, and we should be concerned about what that means for the quality of our healthcare system. So this takes me back to the thesis of this talk. What I've shown you is how, by looking at COVID-19 through an economist's lens, we can see COVID as including, not necessarily limited to, but including this series of demand-side shocks to the healthcare system. Those direct effects are relatively small compared to the potential size of the intermediate and systemic effects, which could have long-term implications for the cost, access, and quality of our healthcare system. And before I end, I do want to note a few bright spots that have emerged from the COVID economy and COVID-19's effects on our healthcare system. One bright spot is telemedicine. Providers and patients alike, and thanks to the flexibility of insurers, have really embraced telemedicine. And if those impacts last beyond the pandemic, telemedicine has the potential to mean more convenient care for more patients at a lower cost. And remember that time cost of traveling to care. This is especially important in areas where physicians are not as readily accessible geographically. Another potential bright spot is that COVID-19 may create an opportunity to rethink how we pay for healthcare. One of the main features of the US healthcare system is something called fee-for-service payment. Physicians and providers charge a fee every time they do a service. This means more services, more fees. But it also means when there's fewer services, there's less fees. And COVID-19 has had that impact. Fewer services, less revenue for physicians. That's something that physicians might even agree is not necessarily beneficial. But switching away from this fee-for-service system might mean efficiencies could be gleaned from improvements. Why should we pay for a fee for every service when it might encourage unnecessary care? Newer models have thought about ways to bundle payments or pay for a global budget of services. This might be more predictable for insurers and providers and might have quality improvements if that payment is tied to quality measures. So it's too early to know how this debate will go, but some have argued and wondered if perhaps this exposure to this COVID-19 shock might facilitate our movement away from fee-for-service and towards more efficient payment mechanisms. So that concludes my talk. I will end here with some of the sources that I used, and I look forward to potentially meeting some of you on your next visit to campus.